Many textbooks begin their study of the skeleton with the skull. But since there are only one pair of movable joints in the entire skull, it really doesn't have much relevance to a study of movement. The other reason I don't start with the skull in my classes is because it is so complicated. In fact, there's so much detailed anatomy in the head and neck that it is the last region I cover in gross anatomy, after the students have adjusted to the rigors of the course. But now that you have a good understanding of the spine, let's stack the skull on top of it. Then we'll expand off the thoracic vertebrae to discuss the rib cage, and we'll also talk about the hyoid bone, a rather unique bone in the neck with forensic importance. Speaking of forensics, as we begin, let's pretend you're one of my students in lab, and this clinical issue relates to your cadaver. As your team begins to remove the skin of the chest to examine the bones, muscles, nerves, and vessels of the anterior chest wall, you notice some internal bleeding around the sternum. However, this subcutaneous blood caused no bruising on the skin. As you look and feel around the area, you discover some ribs and their cartilages are fractured. You begin to suspect that this person might have been in some type of accident or could have been assaulted before death. But shouldn't those cases go to the coroner's office, not to our lab? What do you think happened to this person to cause these injuries? After all, these bodies are not autopsied, well, other than by my students, since I do ask them to look for clues and use their head to try to discern their person's cause of death. So speaking of the head, the human skull is composed of 22 bones united by joints. It is typically divided into a cranial region, often called the brain case, and a facial region that surrounds most of our sensory openings. The cranial region includes 8 bones that have the most direct relationship with the brain and its coverings. There are a pair of parietal bones that make up most of the dome or vault of the skull, a pair of temporal bones on either side of the skull, a single frontal bone in the forehead region, as well as a single occipital bone at the posterior skull. The other 2 bones of the cranial region are a bit more obscure from an external view. One is the sphenoid bone, which is really like an architectural buttress for the skull, since it supports and joins with each of the other 7 cranial bones. The final brain case bone is the ethmoid, and while it has the majority of its anatomy in the facial region, a projection of the ethmoid reaches up to the floor of the brain case, so that's where it's classified. The facial skeleton is composed of 14 bones. There are a pair of zygomatic bones that make up the prominences at the cheeks, and a tiny pair of lacrimal bones in the eye sockets. A pair of nasal bones make up the bridge of the nose, and a singular bone called the vomer helps make up the nasal septum that divides the nasal cavity in 2. The pair of maxillary bones of the midface surround the nasal opening, called the nasal aperture. These maxillae also form the upper jaw. The scientific name given to the unpaired lower jaw is the mandible. The remaining 4 bones are not readily seen externally. 2 are the paired inferior nasal conchae on the sides of the nasal cavity, and a pair of L-shaped palatine bones likewise contribute to the lateral nasal wall, but also help make up the roof of the mouth. The majority of the joints in the skull are known as sutures. Many are interlocking at their edges, like teeth in a zipper, or a dovetail joint in carpentry. These are considered fibrous synarthrotic joints, which remember are immovable and are held together by connective tissue that is dense with fibers. Some practitioners claim the bones of the skull move in adults, but that's controversial. However, the sutures between skull bones in the fetus do move. In fact, the fetal and newborn skull has fontanelles, so-called soft spots, between some of the sutures. And these allow the actual overlap of cranial bones during the birth process, facilitating the journey through the birth canal. In my forensic work, it's clear that the sutures of the skull are somewhat protective in that they relieve some of the stress of a blow. A skull fracture often propagates through a cranial bone, but frequently stops when the fracture reaches a suture, and there the stress is relieved. An exception would be a high-velocity impact, such as in a high-caliber gunshot wound. Those can cross a suture and can shatter a skull. Another forensic application relates to the fact that the sutures of the skull may completely close up with age. They'll literally obliterate. This is definitely more common in the elderly, but I've seen it happen in individuals as early as in their 20s. Decades ago, cranial suture closure used to be more heavily relied on when assessing the age of an unknown person. And while it is somewhat correlated with age, the pattern is not definitive enough to use it as a reliable forensic method. There are names for all the sutures of the skull, but usually only the larger sutures are covered in a basic anatomy course. The coronal suture is between the frontal and paired parietal bones. It sits more or less across the crown of the head, which makes sense since coronal means crown. The sagittal suture runs between the two parietal bones along the mid-sagittal plane. The lambdoid suture is posteriorly between the parietal bones and the occipital bone. Where the parietal bones intersect with the occipital bone, the result resembles an upside-down V, like the Greek letter lambda, and that's why it's called the lambdoid suture. The final major suture often mentioned in a basic anatomy course is the squamous suture found laterally between the temporal bone and the sphenoid and parietal bones. Now, squamous means flat, and not only is this suture less squiggly or jagged than most other sutures, it's also not an interlocking or serrate suture like the others. The squamous suture is what we call a beveled or lap suture, where a pair of flat surfaces simply overlap. For this reason, in forensic cases, especially if the skeletal remains are very dried out, or in archaeological samples, the squamous sutures tend to flare open and separate rather easily because they're more like miter joints than the other sutures. One other interesting feature of cranial sutures is that they can have what are known as sutural bones or Wormian bones within them. Some books call these ossicles, little islands of bone within the suture. When I first studied anatomy in high school, I thought they were called Wormian bones because many sutures are squiggly like a worm. But then I found out that it's an eponym. The W is capitalized. These islands of bone within a suture are named after the Danish physician Ole Wurm. Another set of ossicles associated with the skull are the three tiny bones in the middle ear cavity within each temporal bone. They are named the malleus, incus, and stapes, or as you may have learned in translation, the hammer, anvil, and stirrup. Since these relate to hearing, we won't cover them, but they're interesting and very cool to see. There are so many skull landmarks, we could do an entire lecture series just on the skull. For instance, there are numerous foramina that provide entrance and exit for nerves and blood vessels. Some are only found inside the skull, while others are on its surface or connect through and through. There are also plenty of muscle attachment sites, some to anchor muscles of facial expression, and others, like attachment sites at the base of the skull, for muscles that move the head and neck. And while we can't cover all of these, we can at least talk about some of the ones important to our focus on movement and nerve supply. Let's start externally with some of the major openings. There's a supraorbital foramen or notch just above each eye orbit. In some people, it's a foramen, and in others, just a notch at the edge of the orbit roof. Below each orbit are corresponding infraorbital foramina, satisfying the rule of adjectives. Also, in vertical alignment with those are a pair of mental foramina in the mandible. This series of three bilateral openings transmits three paired branches of the fifth cranial nerve called the trigeminal nerve and their corresponding veins and arteries. Now, these nerves are responsible for sensations from the facial skin. The eye orbits contain several openings. The optic canal that transmits our optic nerve, which is the cranial nerve of vision, as well as a small artery that supplies structures in the orbit. There are also superior and inferior orbital fissures that transmit branches of other cranial nerves, including the motor nerves that supply muscles that move the eyeballs around. Progressing laterally, there is an external auditory meatus on each side of the skull. A meatus is a tube-like passage in a bone. This is lined with skin and transmits sound waves into the eardrum. Posteriorly is the largest foramen in the skull, the foramen magnum, which is Latin for big hole. Pretty descriptive, huh? Foramen magnum transmits the brainstem where it becomes the spinal cord and also allows entrance of the vertebral arteries that ascend the neck through the transverse foramina of our cervical vertebrae. On either side of foramen magnum are the occipital condyles that articulate with the first cervical vertebra. At the base of the skull, there are many other openings in such detail that we won't be able to cover them here. Several of these openings transmit cranial nerves that provide sensation and motor control to structures mostly in the head and neck. Other passages are routes for blood vessels that need to enter the cranium, like the internal carotid arteries that work with the vertebral arteries to supply the brain. Some openings also transmit veins, like the internal jugular veins that leave the skull, leading blood low in oxygen away from the brain. And with the skull cap removed, we can see that there are just as many openings inside the skull. These passages are also the means by which nerves and vessels communicate between the head and neck, or relay our special senses. Several pairs of cranial nerves are devoted to the special senses, which include sight, smell, taste, hearing, and equilibrium. Equilibrium is our special sense of balance maintenance, housed in the inner ear along with the sense of hearing. Now, if you thought I was going to finish with touch, realize that your middle school teachers may have told you a bit of a fib. There are 5 special senses, but touch is not one of them. Touch is known as a general sense, since general senses are found all over the body and have relatively simple receptors, while special senses have complicated receptors, all of which are located in the head. At the posterior aspect of the skull are nuchal lines on the occipital bone. These are the attachment sites for some true back muscles in the neck. Behind each ear, you can feel the bumps created by our mastoid processes. And there are styloid processes that are just medial to them. Now, these landmarks are both on our temporal bones and are attachment sites for muscles in the neck. 2 other bony landmarks at the base of the skull are the medial and lateral pterygoid plates of the sphenoid bone. PTER means wing, as in the winged dinosaurs called pterodactyls. These pterygoid plates are attachment sites for muscles that help move the jaw. Laterally, the zygomatic arch, a bridge made partly of the zygomatic bone and partly by the temporal bone, can be easily felt passing posteriorly from the cheekbone. Laterally on the cranium, temporal lines stretch from the frontal bone to the parietal bone. The zygomatic arch and temporal lines are major origins for 2 major muscles of chewing, as we'll later see. The mandible has many bony landmarks, including for the insertions of the muscles that move it. The main portion of the jaw is the mandibular body, and the chin is called the mental protuberance. The angle of the jaw is located posteriorly, and the mandible's ramus projects superiorly to terminate in the coronoid process anteriorly and the mandibular condyle posteriorly. Now, the condyle is also known as the head of the mandible, and just inferior to it is a constricted neck. The mandibular condyle articulates with the mandibular fossa on the temporal bone. Now, that forms the only movable joint of the skull, the temporomandibular joint, more commonly called the TMJ. We'll cover the muscles and movements of the jaw in a future lesson and return to these bony landmarks when we do. Now, since I can't help but insert some anthropology, there are differences between male and female skulls. On average, the bones of males are larger than females after puberty. This is because testosterone causes a longer period of bone growth, and it also influences muscle mass, which can enlarge muscle attachment sites. So, following puberty, male skulls, as well as other bones, are generally larger and more robust, meaning they're more developed at their muscle attachment sites than those of females. As a result, males often have larger brow ridges on their frontal bone, more robust zygomatic arches, larger mastoid processes, and a rougher nuchal region where neck muscles attach. Females retain the more gracile, bony landmarks of their skull after puberty. So women tend to have a smoother brow ridge, slight zygomatic arches, generally smaller mastoid processes, and a smoother nuchal region. Now, this is not absolute. Many of us are a blend of male and female skeletal characteristics, and the expression of each of them is on a continuum. The female jaw generally has a more obtuse mandibular angle, where the body meets the ramus, and a chin that typically comes to a single point in front. A male jaw frequently has a more 90-degree angle and often comes to 2 points anteriorly that tend to square off the mandible in front. Now, if this interests you, palpate your own skull and maybe those of partners or good friends and see if you can identify differences between males and females. In addition, some of the geometry and bony landmarks of the midface region can be used in forensic anthropology in an attempt to assess a person's ancestry or population affinity, which society may call their race. Features like the distances between the eye orbits, the width of the nasal aperture, and shape of the nasal bones, the degree of projection of the upper and lower jaw. These can vary in people of different ancestries. The measurements of those features fed into computer software can contribute to the biological profile of an unknown person. For example, whether they're male or female, and if their skull shows ancestral traits that may help get them identified by the medical legal system. Now, let's move inferior to the skull to discuss the hyoid bone. It is unique within the skeleton because it's the only bone in the body that doesn't directly articulate with another bone. That's not to say the hyoid bone is completely free-floating. It is attached to the cartilages of the larynx or voice box that sits inferior to it, and it's also attached to muscles of the neck, but it doesn't have a joint with any other bone. The hyoid sits posterior and roughly parallel to the mandible. So if you gently move the structures in your anterior neck from side to side for several seconds, you might begin to sense almost a pins and needles feeling at the base of your tongue. This is because the tongue is anchored all the way down to the hyoid bone. Due to its location, the hyoid bone is often fractured in cases of manual strangulation. Of course, a fractured hyoid bone doesn't prove strangulation, but after bruising and other soft tissue evidence are decomposed, many pathologists find a fractured hyoid bone suggestive of strangulation, especially if it's the only bone in the body that's broken. We covered the thoracic vertebrae in the previous lesson. So now let's look at how their companion ribs and the sternum form the complex known as the rib cage. We know there are 12 thoracic vertebrae, and each is attached to a pair of ribs. Now, ribs have their own anatomical landmarks. Beginning posteriorly, there's the rib head, followed by a neck, and then a projection known as the tubercle. From the tubercle extends the shaft of the rib, which curves in what's known as the rib's angle, as the rib passes from posteriorly to laterally and then anteriorly. On the inferior and deep or medial surface of the rib is what's known as the costal groove, in which intercostal nerves and vessels run. The sternal end of the rib is most anterior. That's the anatomy of a typical rib, but not all ribs are created equally. For one thing, the ribs start out shorter in length and then get longer and ultimately shorten again. This results in a rib cage that is narrow superiorly and inferiorly, but wider intermediately. The angles of the ribs also change in curvature throughout the rib cage. And while all ribs attach to the spine posteriorly, they don't all attach to the vertebral column in the same way, as we'll see. In addition, not all ribs attach to the sternum anteriorly. The first 7 pairs of ribs have their own costal cartilages that attach them to the sternum, so they're called true ribs. But rib pairs 8, 9, and 10 usually borrow the cartilage of rib 7 to reach the sternum. And rib pairs 11 and 12 don't attach to the sternum at all. For this reason, pairs 8 through 12 are known as false ribs, and pairs 11 and 12 are subgrouped as floating ribs. You may have learned that floating ribs are their own third category, but there are technically 7 pairs of true ribs, 5 pairs of false ribs, and of the false ribs, the last 2 pairs may be called floating ribs. To better understand this concept, let's take a look at the sternum. The sternum is generally counted as one bone among the standard number of 206 bones in the average human body. But it has subunits. The superior portion of the sternum is the manubrium. Then there's the blade-like body of the sternum, which antique books often call the gladiolus, for the blade carried by gladiators. The inferior tip of the sternum is called the xiphoid process, and it's cartilaginous in young people, but typically ossifies with age. At the superior edge of the manubrium is the suprasternal notch, also called the jugular notch. It feels deeper on us than it actually is on the manubrium because of the clavicles on either side. These join the manubrium at its paired clavicular notches, which are just lateral to the suprasternal notch. The articulation where the manubrium meets the body of the sternum often projects slightly anteriorly and is called the sternal angle. Now, you may be able to palpate it on yourself if you take a few finger pads and move them up and down on your sternum. A couple of inches inferior to the suprasternal notch, you may feel a horizontal ridge that projects forward where the manubrium meets the sternum, though it's more pronounced in some people than in others. The sternal angle is an important anatomical landmark. It's where the aorta begins and ends its arch from the heart before descending through the chest as a thoracic aorta. It's also where the trachea or windpipe bifurcates into a pair of bronchi that enter each lung. It often surprises people when they learn that the trachea ends that far superiorly. And if you sent a horizontal plane straight back from the sternal angle, you would intersect the T4-T5 intervertebral disc. But the importance of the sternal angle to the rib cage is that it is where the costal cartilage of the second rib attaches to the sternum. For this reason, paramedics and other health professionals can use that sternal angle to quickly locate the second rib, and from there more readily figure out and assess other ribs. The first rib attaches by its costal cartilage to the manubrium. The second rib attaches to the sternum at that sternal angle between the manubrium and the body. And the costal cartilages of ribs 3 through 7 attach to the body of the sternum. Remember, a true rib has its own cartilage connecting it to the sternum. Now, these sternocostal joints are gliding or planar synovial joints. The costal cartilages of ribs 8, 9, and 10 link up to the 7th costal cartilage to reach the sternum, and in so doing form the surface anatomy landmark called the costal arch. If you ask a little kid or someone thin to suck in their belly, you can see that costal arch that's formed by the ascending cartilages of ribs 8 through 10 reaching that cartilage of rib 7 in their collective path to the sternum. I should also mention that the costal cartilages tend to ossify with age. And this is helpful in assessing the age of an unknown skeleton at the morgue, which can be done visually from dried bones or by using x-rays in a body that's not skeletonized. Now, there's no precise method to determine age from this, but when ossification of the costal cartilages is seen, it usually indicates an older person. In addition, as costal cartilages turn to bone, someone doing life-saving cardiopulmonary resuscitation, or CPR, on an older person may hear fractures occurring during chest compressions. And while that's unfortunate, if CPR saves a life, I'd bet that's certainly worth some fractured costal cartilages or ribs. Now, if that sounds familiar, that's what I was getting at in our clinical correlation. We sometimes see signs of CPR fractures and other life-saving attempts in our cadaver population in the gross anatomy lab. When we see fractured ribs and rib cartilages and blood that escaped in the chest wall in a cadaver, it's typically a sign that someone believed the individual was having a heart attack and tried to save them, unfortunately to no avail. The bruising doesn't reach the skin because the person died and his or her heart stopped pumping blood. In other cases, we see extensive bruising in the antecubital space in front of the elbow, and perhaps a port under the skin of the chest for delivering long-term doses of medication like pain-relieving drugs. From that, you get the sense that the person likely died in a hospital setting after a lengthy illness. As we progress in the dissection, we very often get clues as to how the person may have died. We also see things that maybe they and their physician didn't even know were there. If we ask for it, we can find out the individual's cause of death as assessed by their physician at their passing. But keep in mind that these were body donors and therefore were not coroner's cases who received an autopsy. So to get back to the rib cage, let's finish up by taking a look at how the ribs attach posteriorly to the vertebrae and then relate this to the intercostal nerves. Ribs don't just attach in one place to their respective vertebra. They attach in two places, which facilitates stability and movement. Remember the body and transverse processes of a vertebra? The head of a rib attaches to the body of a single thoracic vertebra, or it may span across the bodies of two thoracic vertebrae. In the superior and inferior portions of the rib cage, the rib head will attach to a single thoracic vertebral body. And in the mid-range ribs, they attach to costal facets on two adjacent vertebrae, along with the intervening disc between them. Regardless, the tubercle of each rib attaches to the transverse process of the thoracic vertebra it corresponds to. So the tubercle of rib 7 attaches to the transverse process of the T7 vertebra, even though the rib's head attaches to both T6 and T7. These so-called costovertebral joints are gliding synovial articulations, so are freely movable. When we study the muscles of the rib cage, we'll better understand the actions at these joints. Related to this, remember that there are intervertebral foramina between adjacent vertebrae, and out of those come spinal nerves that almost immediately branch into dorsal and ventral rami for distribution to tissues. In the thoracic region, the ventral rami of those spinal nerves are called intercostal nerves, and assume a simple pattern that hugs the inferomedial side of the ribs, running in the costal grooves on the deep surfaces of the ribs. These intercostal nerves have sensory components that govern segmental patches of skin on the thorax, which we learned are called dermatome patterns. But the intercostal nerves also supply the muscles of the rib cage, as well as muscles of the anterolateral abdominal wall. We'll see that the ventral ramus of the first intercostal nerve, T1, also participates in the brachial plexus that governs the sensory and motor supply of the upper limb. We've covered the entire axial skeleton in these last two lessons: the skull, vertebral column, ribs, sternum, and hyoid bone, and it was a lot of information to digest. Refresh your memory as you need to before moving on to the next lesson, where we'll see how the bones, joints, nerves, and muscles in this region all come together to cause movement.